Hello everyone, this is Dr. Yvette Mong Batar, your inculcator for this module. In this module, we will be learning about Family Nursing Process or FNP. FNP is the application of same nursing process that you learned in your first year, as it is being applied to the family. Remember that in community health nursing, we have the following patients or clients: the individual, the family, and the community. So this module focuses only on the family as a client or patient. The concept that we will be learning in this module are the following. First are the tools for assessment. So for that, we have initial database, typology of nursing problems in family nursing practice, family health task, and family coping index. Then we also have the family data analysis, which includes socioeconomic and cultural characteristics, home environment, family health status, and family health values and health practices. The first concept that we will tackle in this module are the tools for assessment that is used to collect data in order to come up with a family care plan. But before proceeding into the different tools, we will take a tour on the FCP concepts. Specifically, we will visit the definition of family care plan. FCP is the blueprint of the care that the nurse designs to systematically minimize or eliminate the identified health and nursing problem through explicitly formulated outcomes of care. So they are actually the goals and objectives and deliberately chosen set of interventions, resources, and evaluation criteria, standards, methods, and tools. So we have characteristics which are based on the concept of planning as a process. So first we have there is that the family care plan focuses on actions which are designed to solve or minimize existing problem. So the course of the plan are the approaches, strategies, activities, methods, and materials which the nurse hopes will improve the problem. Then FCP is a product of the deliberate systematic process. It is, as with all other plans, relate to the future. So it utilizes events in the past and what is happening in the present to determine patterns. It also projects the future scenario if the situation is not corrected. Another characteristic is that the FCP is based upon identified health and nursing problems. FCP is a means to an end, not an end in itself. So the goal in planning in FCP is to deliver the most appropriate care to the client by eliminating barriers to the family health development. Then last but not the least, among the characteristics is that FCP is a continuous process, not a one-shot deal. So it would mean that the results of the evaluation of the plan's effectiveness, which we will be doing at the end, triggers another cycle of the planning process until the health and nursing problems are eliminated. We move on into the desirable qualities of a nursing care plan. Number 1, it is based on clear, explicit definition of the problem or problems. 2, it's realistic. 3, prepared jointly with the family. And 4, it is in written form. For the importance of planning care, why we are doing it. 1, it individualizes care to clients. 2, it helps in setting priorities by providing information about the client as well as the nature of his problem. 3, promotes systematic communication among those involved in the healthcare effort. 4, continuity of care is facilitated through the use of nursing care plans. And 5, is to facilitate the coordination of care by making known to other members of the health team what the nurse is doing. Okay, by the way, in number 4, it says continuity of care is facilitated through the use of nursing care plans. So meaning the gaps and duplications in the services provided are minimized if we do that. Okay, so we minimize it if not totally eliminated. We move on into the steps in developing care plan. So first that we do is to prioritize the problem. So we do priority setting. So we prioritize conditions of the problem. Next is to establish goals and objectives. And after that, we are to select appropriate family nursing interventions or strategy. In short, we will be preparing a plan of interventions. And then lastly, is we do evaluation for the care that we have implemented. So as mentioned at the start, so we have tools for assessment. I will not repeat them anymore. Anyway, both these steps in developing care plan and the tools will be elucidated as we go along with this module. So that we will elucidate first the tools for assessment. So first we have there is the initial database, or that is also known to be assessment database or ADB. Data to be assessed and collected for the initial database or ADB are the following: family structure, characteristics, and dynamics. So meaning we are to assess the composition of the family and demographic data. So we'll be determining the type of family and structure, the interpersonal relationship, the communication patterns of the family. What is the type of family? Is it nuclear, extended, multi-generational, dyad, blended, gay, lesbian family? Is it matriarchal, patriarchal, or is it a communal family, and so on and so forth. Then second we have there is the socio-economic and cultural characteristics. So this is all about the occupation of the family members or members of the household, the place of work, the income of each working member, the educational attainment of each member, the ethnic background, religion, traditions, and practices affecting health, and etc. So of course the poverty will also be included there. And then the different nature of religion, so that is why we have their socio-cultural, which will also be included in the assessment. Next we have is home and environmental factors. So these are information on housing and sanitation facilities. The kind of neighborhood will be assessed, and the availability of social, health, communication, and transportation facilities in the community. We will also be including under that the treatment of garbage, preparation of food, availability of toilet, water, and food preparation, and even sources of diseases. Next we have is health assessment or status of each member. So in our assessment, we will be including current and past significant health conditions or illnesses of the members of the household. So we also include beliefs and practices conducive to health and illness, the nutritional and developmental status, and physical assessment of all the household members. So for that, we will be taking the medical history, no, if there are history of certain disease, and then if there is a family member with disease, and then we also have to gather data about resources that is available in the community for the use of the family. The resources available in the community includes the 5 M's. So we'll be assessing these 5 M's. So first we have, the first M we have is man or manpower. Second M is money. Third M is machine. Fourth M is materials. And the fifth one is method. Last but not the least, among the tools, specifically initial database, is value and practices placed on health promotion, or it is all about maintenance and promotion of disease. So this is all about promotive, preventive services, evidenced by immunization status. So it would mean we will also be assessing the immunization status of the household member, especially children. Use of healthy lifestyle will also be assessed. The adequacy of sleep or rest. No? So, different ages has different sleep requirements also. No? Like adults, 7 to 9 hours, no, is recommended. And then, of course, the younger ones have also longer hours of sleep requirement. And of course, we have to assess exercise and etc. We will continue with tool number 2, which is the typology of nursing problems and family nursing practice. So, this tool comprises 2 parts, the first level assessment and the second level assessment. So, we will go first with the first level assessment. First level assessment is to determine the problems of family after identifying it according to nature. Okay, by the way, in our assessment, when we do family care process, included in the tool that we will be using are the initial database, and then it will be followed by the typology of nursing. So kindly refer into the family nursing care plan tool that was also uploaded into our virtual classroom. So the initial database is included in our sources of problems. So as mentioned in first level assessment, okay, the first level assessment defines the problem after identifying it according to nature. So I would just like to make mention that the nature of the problem could either be health threat, health deficit, and foreseeable crisis or stress points. So though the wellness potential is included in the assessment, but it is not included in the criteria for problem prioritization computation. So later, when we prioritize the problem, we will do computation. But then, you will notice later that the wellness state is not included. No? Why? Wellness state is not a problem. So therefore, we will only be computing when it comes to prioritization of the problem, the health threat, the health deficit, and the stress points. No? So you might be asking, Ma'am, why we need to include the wellness potential when it is not a problem? Of course, we need to include that in the assessment in order to know also their strengths. No? And by knowing the strength, also the community will also feel good about it. Okay? It may motivate them more to go on with their healthy practices. So the wellness state or the potential or readiness capability. So the wellness potential is a nursing judgment on wellness state or condition based on client's performance, current competencies or performance, clinical data or explicit expression of desire to achieve a higher level of state or function in a specific area on health promotion and maintenance. Health threats, on the other hand, are conditions that are conducive to disease, accident, or failure to realize one's health potential. While health deficits are instances of failure in health maintenance, like disease, disability, and developmental lag, and stress points or foreseeable crisis situation are those anticipated periods of unusual demand on the individual or family in terms of adjustment or family resources. Okay. We will now proceed into the second level assessment. In second level assessment, we will be assessing the following: inability to recognize the presence of the condition or problem, inability to make decisions with respect to taking appropriate health action, then inability to provide adequate nursing care to the sick, disabled, dependent, or vulnerable or at-risk member of the family, an inability to provide a home environment conducive to health maintenance and personal development. So, as to the causes of these inabilities, kindly refer to the FCP assessment tool I mentioned a while ago, the one that is provided in our virtual classroom. So, for its component there, you will be seeing in our assessment tool what could be the possible reason or reasons why they have these disabilities. No? So, when you are to do your assessment, of course, you will be using that tool. Then, you will be able to find out what are the cause, or what is the cause, or what are the causes of such inabilities. Then, after we have now the problem, then we do problem prioritization. So, by the way, the second level of analysis ends with a definition of family nursing problems. Again, I would like to reiterate that the end result of the second level assessment is a set of family nursing problems for each health condition or problem. Okay? So, after determining the family nursing problems for its health condition or problem, we will then proceed to the first step in developing care plan, which is priority setting. So, we will now do problem prioritization. So, as seen in the table under problem prioritization, we have there the criteria in identifying the problem. So, actually, we have there, first of all, the nature of the problem, which will be assessed by the public health worker. Okay? So, under nature of problem, we have health deficit, health threat, and foreseeable crisis. We mentioned it already kanina that the wellness state will not be included in prioritization of the problem since those are not problems. Then, we have the modifiability of the problem, which refers to the probability of success in enhancing the wellness state, improving the condition, minimizing, alleviating, or totally eradicating the problem through intervention. So we will to look closer into the problem. Can this problem be modified? Okay, like for example, if the problem is overweight, can we do something about it to modify? Okay, can we enhance wellness state or improve the condition? Can we minimize the weight? No? So those are just examples of that. So if ever the problem is easily modifiable, okay, we give a score of 2 points. That is the maximum. Okay, so by the way, for the health deficit, the score given is 3. For the health threat, it's 2. Foreseeable crisis is 1. And the weight of that problem is 1. So for the modifiability, again, if it is easily modifiable, we give a score of 2. That is the maximum. And then the moderately modifiable or partially modifiable or intermediate, okay, we give 1 point. If it is not modifiable, like for example, hereditary, then we give a score of 0. Next we have is the preventive potential. So that refers to the nature and magnitude of future problems that can be maximized or totally prevented if intervention is done on the problem under consideration. So, our highest score there is 3 if it is highly preventive. And then, if moderate, we give a score of 2. And if low, we give a score of 1. And the weight of that is 1. No? So, sa modifiability lang ang nakalahi because it's 2. And then, for the salience of the problem. The salience refers to the family's perception and evaluation of the problem when it comes to seriousness. No, because there are problems, class, nga for the family, it's not serious. But for you, as a public health worker or nurse, serious na to siya. No, but then, for the salience, it's the family's perception and evaluation of the problem's seriousness that we are to consider. So, if it is high, no, so the problem is needing urgent attention, so meaning to say, high na siya, it is serious and needs immediate action, then we give a score of 2. If moderate, or meaning the problem is serious, but it does not need immediate action, then we give a score of 1. If it is low, meaning to say the family does not see it as a problem, then we give a score of 0. So I remember before, we had a family client that the children experience ascariasis, kanabitang bitok, gipang bitok, and according to the mother, it's not a problem because for her, the ascariasis or the bitok is just normal occurrence in children. Okay. So we have here an example for our problem prioritization. So this is the family number 1 or the De La Cruz family. So one of their problems noted was cough and cold. So we will compute its priority score. So the formula will be score given divided by highest score per category times weight of the problem. So the first step that we do in scoring is we are to decide on a score. So the ones in red color are the score given for each category in this example. Okay? So like the nature of the problem, okay, it's health deficit according to the assessment. So therefore, that was given is score of 3. And the weight for the nature of the problem is 1. So when we compute that, diba, atong formula is score given over highest. So that is 3 over 3 times the weight, which is 1. So the actual score is 1. The justification of that, since we will always be providing justification, is it is a health deficit since it is an instance of failure in health maintenance. No? So, then, we go into the modifiability of the problem. So, the problem is modifiable. No? So, meaning it is removable. So, therefore, we give a score of 2. The weight under that category, modifiability, is 2. So, therefore, in the computation, score given is 2. Highest score is 2 times 2. So, which is itong weight. So, actual score is 2. Our justification for that is that the family and the community has the necessary resources to treat cough and colds. No? Kaya there are kanang health centers in the nearby places and also clinics, no? Mga hospitals, private clinics. And then, for the preventive potential. So, the problem was given a score of 2 for the preventive potential, meaning it's moderate. So, the highest score for that category is 3. So, we have there 2 over 3 times the weight, which is 1. So, the actual score is 0.67. Justification for that is possibility of transferring infection to other members of the family is high and should therefore be given immediate attention. Mother knows ways of treating cough and colds and has used herbal medicine. Then, last but not the least, is the salience of the problem. So, the salience is high, meaning it needs immediate attention. So, therefore, it was given the highest score 2. So, the weight for that criteria is 1. So, therefore, we have there the score given 2 over the highest score, that is 2, times the weight in that category, which is 1. So, the actual score is 1. And the justification for that, although the infection is not life-threatening, there is possibility of transferring the infection to other family members. And right after that, we are to get the sum total of all the scores. So, we add 1 plus 2 plus 0.67 plus 1. So, we have there a total score of 4.67. So, our perfect score is 5. So, therefore, if your computation is more than 5, it means that you did it wrong. So, if the score is nearing 5, like the one in our example, 4.67, then prioritize the problem. So, the criteria 1, 2, and 3 has to be assessed objectively by the health worker. Meaning to say, if you are the nurse assessing it, then criteria 1, 2, and 3 has to be assessed by you objectively. You will be the one to give the score. But for the criteria number 4, it has to be assessed by the perception of the family. And you just do the same to the rest of the problems noted. Then rank them according to scores. The highest is the score, then the more that we make that problem a priority. But then we are to consider the resources. Kaya even though class, it's the highest score, no? It has the highest score among the problems that existed for that family. But if you can do nothing about it, like for example, they lack CR, no, or comfort room, you cannot do something about it. Alangan naman you will build a toilet or CR for them. So in that case, do not make it your priority problem, no? Kaya during sa evaluation stage, so of course, nothing to evaluate yun, zero jud kadad to. It's because you cannot do something about the problem. So the ranking with health problems of family de la Cruz, so this is just an example, okay, granting that we did already the computation for the rest of the family's problems nga noted, then we have to prioritize that according to scores. So, suppose these are the top 3 problems of family de la Cruz, so we rank them according to highest, from highest to lowest scores, 5 being the highest. So to sum it up, our typology of nursing problems in the family nursing practice comprises the first and second level assessment. For the first level assessment, we have their presence of wellness condition, presence of health threat, the presence of health deficit, presence of stress points or foreseeable crisis or situation. But when it comes to computation of the problem, okay, the presence of wellness is not included in the criteria. Then for the second level assessment, so it includes inability to recognize the presence of the condition or problem, then inability to make decisions with respect to taking appropriate health action, then inability to provide adequate nursing care to the sick, disabled, dependent, or vulnerable at-risk member of the family, and inability to provide a home environment conducive to health and maintenance and personal development, and lastly, but not the least, inability to utilize community resources for the healthcare. So our criteria for ranking health conditions and problems according to priorities are the nature of the condition or problem presented, modifiability of the condition or the problem, the preventive potential, and the salience of the problem. Okay, tool number 3 we have is family health tasks. So here we will be assessing whether or not the family have done their tasks. So the first task for a public health worker like nurses and midwives under this tool is to provide the family members with means for health promotion and disease prevention. Like for example, examples of family health tasks: breastfeeding, healthy diet for the family, immunization of children, health teaching about hand washing, and etc. So we have to remember that an important responsibility of the community nurse under this family health task is to develop the family's capability in performing its health task. So aside from that, aside that task of ours, which is providing members means for health promotion and disease prevention, there are also other health tasks according to Freeman and Henrich. So, and we have recognizing interruptions of health or development. So this is a requisite step the family has to take to be able to deal purposely with an unacceptable health condition. Then seeking health care. So this is when health needs of family are beyond its capability in terms of knowledge, skills, or available time. The family consults with the health workers since it cannot anymore be managed at their level. And then managing health in non-health crisis. So the crisis, whether health related or not, is a fact of life that the family has to learn to deal with. The family's ability to cope with crisis and develop from its experience is an indicator of a healthy family. Then, providing nursing care to the sick, disabled, or dependent members of the family. So, in addition to the care of the very young and the very old, many minor illnesses, chronic conditions, and disabilities require home management by responsible family members. Then we have maintaining a home environment conducive to good health and personal development. So this is actually in addition to safe and healthful. Sorry for that. Okay, this is in addition to safe and healthful physical environment. The home should also have an atmosphere of security and comfort to allow for psychosocial development. And then maintaining a reciprocal relationship with the community and its health institutions. So just as the family utilizes community resources, like those resources at the health centers, okay, the family also takes interest in what is happening in the community, and depending on the availability of family members and family's perception of its need and appropriateness, gets involved in community events. Then the fourth tool we have, which is the last tool that we are to discuss in this module, is the Family Coping Index, which is an alternative tool for nursing diagnosis. So this Family Coping Index provides a system of identifying areas that may require nursing intervention and areas of family strengths that may be used to help the family deal with health needs and problems. So this focuses on identifying coping problems of family in 9 areas of assessment. So we call that 9 areas of assessment of Family Coping Index. First we have is physical independence therapeutic. Oh, sorry for that. The therapeutic competence should be number 2. Okay, number 1 is physical independence, which refers to the family member's mobility and ability to perform ADL or activity for daily living. Like for example, okay, they have the ability to feed themselves, perform activities necessary for personal hygiene. Then number 2 is therapeutic competence. So that is family's ability to comply with prescribed or recommended procedures and treatments to be done at home, which include modifications, dietary recommendations, exercise, application of wound dressings, and use of prosthetic devices and other adaptive appliances such as wheelchairs and walkers. Number 3 is knowledge of health condition. So that means understanding of health condition or essentials of care according to developmental stages of family members. Like, for example, degree of knowledge of family members in terms of communicable disease and its modes of transmission, or that diseases, or if that disease is genetically transmitted, like for example, the diabetes mellitus. Number 4 is application of principles of personal and general hygiene. So this includes practice of general health promotion and recommendation of preventive measures. Number 5 is healthcare attitudes. So this refers to families' perception of healthcare in general, and this is observed in the family's degree of responsiveness to promotive, preventive, and curative efforts of health workers. Then 6 is emotional competence, which is concerned with the degree of emotional maturity in family members according to their developmental stage. The developmental stage which will be discussed, I guess, in your maternal child nursing. And this emotional competence may be observed in behaviors such as how the family members deal with daily challenges, their ability to sacrifice and think of others, and acceptance of responsibility. The number 7 is family living patterns, which refer to interpersonal relationships among family members, management of family finances, and the type of discipline in the home. 8 is physical environment, which includes home, school, work, and community environment that may influence the health of family members. Then 9 is the use of community facilities, and this is the ability of the family to seek and utilize as needed both government-run and private health, education, and other community services. And that is the end for this set of slides. Thank you for your attention.